Okay, so good morning, everyone. I'd like to start by thanking CRY for inviting me to give this talk, which is on hypertrophic cardiomyopathy, its diagnosis and management. So just to start with, I'm going to set out some learning objectives for this talk. The first one is to recognise the clinical heterogeneity of HCM and the wide variety of ways in which patients can present. I'd also like people to understand the pathophysiology of HCM and also recognise its diagnostic features and, importantly, the high-risk features. And finally, I want people to go away with some understanding of the management of the condition. So just start with a little bit of historical perspective. And an enlarged heart with obstruction to blood flow was described throughout the 17th and 18th centuries and associated with various symptoms, including palpitation, chest pain, and syncope, which was then known as swooning. This man, Lancisi, published a book in 1705, where again he made a correlation between an enlarged heart and sudden death. However, it's not until about 1869 where this Frenchman, Henri Louville, gave the earliest descriptions of the condition in the Paris Gazette. So moving on to the 20th century, and this British cardiologist, William Evans, gave a talk about hypertrophic cardiomyopathy at the annual BCS conference in 1947. And he recognised it as a familial condition and termed it familial cardiomegaly. However, it was not until 1958 where this man, who's a pathologist, Danter, working at St George's Hospital at Hyde Park Corner, that's where it was located then, gave the contemporary description of HCM as a distinct disease entity. So we've moved on a long way from then, and as you all know, HCM is a cardiomyopathy, and this is the ESC's current classification of cardiomyopathies. And if you'll note, they actually classify a whole host of conditions as HCM. But for the purposes of this talk, I'm going to stick to that which you and I probably recognise as HCM, i.e. HCM due to sarcomeric protein mutations. So using this as a basis, the definition of hypertrophic cardiomyopathy is an intrinsic myocardial disorder, which is characterised by unexplained left ventricular hypertrophy, usually greater than or equal to 15 millimetres, along with a non-dilated ventricular chamber and the absence of a cardiac condition or systemic disease that's capable of producing the same amount of hypertrophy. Now, there are a couple of caveats to this description in that actually any wall thickness above 12 can be compatible with HCM, and in the end stages of the disease, dilatation may be present. So moving on to the epidemiology, and this is as diverse as the condition itself. HCM has a prevalence in the general population of 1 in 500, which accounts to about 120,000 people being affected in the UK. As you heard in the talk by Michael Papadakis earlier this year, it's not an infrequent cause of sudden death in young people, and particularly in young athletes, it's the commonest cause in some areas of the world. HCM is truly a global disease with cases described in over 50 countries and across all continents, and it affects both sexes equally. It also affects all races with similar mutations, and it's unique in the cardiac conditions in that it can present anywhere throughout life, all the way from infancy to over the age of 90. Now, most of our understanding of the genetics and inheritance of HCM has come from familial studies performed in the 1980s. And we know that it has an autosomal dominant mode of inheritance, meaning that each offspring of an infected individual has a 50% chance of inheriting the disease. There are some caveats to this as well, though, in that sporadic cases may arise due to de novo mutations. We now know that HCM can be caused by mutations in over 11 genes, and the majority of these encode the thick and thin myofilament sarcomeric proteins and protein components of the adjacent Z disc. Now, the majority of cases are due to mutations in the genes encoding for myosin-binding protein C and beta-myosin heavy chain, which together account for approximately 70% of cases. Cardiac troponin T accounts for about 5% or less, with the mutations in the remainder of the genes accounting for the other 25%. Now, HCM does show a lot of genetic heterogeneity as well, and to date, over 1,400 mutations have been described. It's perhaps partly because of this that we also see a lot of phenotypic heterogeneity, not only between different families, but also within. So, for example, one member of a family may have quite severe disease and present at an early age, whereas another member of the same family with the same mutation may present much later and have a milder form. So expression is variable and age-related. And this may be due to the role of environmental factors and modifier genes, but we're not entirely sure why at present. In addition, the diagnostic yield for causal mutations is only about 60 to 70% at present. And this may simply be because we just haven't discovered all the mutations that can cause HCM. And finally, even though attempts have been made in the past, for example, trying to correlate mutations in a particular gene with phenotype and the severity of disease, at present, no robust genotype-phenotype correlations exist, although we know that patients who have more than one mutation or who are homozygous generally have more severe disease. So moving on to the pathophysiology, and obviously the macroscopic hallmark of the condition is left ventricular hypertrophy. However, it's important to remember that the right ventricle can also be affected. These are cardiac MRI images from patients with HCM, and again, I just want you to note the heterogeneity. So, for example, this patient here has severe hypertrophy affecting all of the septum, whereas this patient has milder hypertrophy just affecting the base. In addition, other patterns can be seen: apical hypertrophy, hypertrophy affecting the other segments, such as the anterior wall, and a more concentric pattern as well. It's important to realize that not only HCM doesn't only cause left ventricular hypertrophy, but structural abnormalities of the papillary muscles and mitral valve can also occur. And this is important to note because they contribute significantly to the development of what we call systolic anterior motion of the mitral valve leaflet, or SAM, which accounts for a lot of the pathophysiology of the condition from a clinical perspective. I'll come back to talking about this later, but if we say that this is a normal papillary muscle architecture, changes in HCM that we may observe are apical displacement of the papillary muscles, abnormal caudal attachment of the mitral valve leaflets, bifid papillary muscles, hypertrophy papillary muscles, or elongated mitral valve leaflets. Moving on to histology, and the hallmark of HCM is myocyte hypertrophy and disarray. However, it's important to know that other features may also be present, including arteriolar hyperplasia and, importantly, fibrosis. So taking all these features together can account for much of the clinical pathophysiology we observe in day-to-day practice. So a hypertrophied septum with mitral valve and papillary muscle abnormalities can lead to left ventricular outflow obstruction in SAM, which in turn can cause chest pain, breathlessness, and syncope. The SAM, or systolic anterior motion of the mitral valve leaflet, can also cause mitral regurgitation, which may lead to breathlessness. And a stiffened ventricle with fibrosis may lead to diastolic dysfunction, which can again cause shortness of breath. A large muscle mass with arteriolar hyperplasia may lead to myocardial ischemia and chest pain. And disruption of the normal myocardial architecture with fibrosis can predispose individuals to ventricular arrhythmias such as ventricular tachycardia, but importantly also supraventricular arrhythmias such as atrial fibrillation, which can occur in 22% of patients and is a risk factor for stroke in these individuals. And finally, there's evidence now that autonomic dysfunction may also be present in HCM, which again can account for some of the clinical features such as blunted blood pressure response, which I'll come on to talk about later. So moving on to the clinical features, now obviously patients may have a family history of the condition or have a family history of sudden death, which is a red flag feature. But in terms of symptoms themselves, again, there's much heterogeneity. Some patients may be entirely asymptomatic, but when present, symptoms include chest pain, breathlessness, palpitation, and syncope again is another red flag feature. In the later stages of the disease, other symptoms of heart failure may also be present, such as orthopnea, PND, or ankle swelling, but this is only in the burnt out phase normally. An examination may reveal a forceful apex and systolic murmur. So moving on to diagnosis and risk stratification. Now, diagnosis may be prompted by symptoms, examination, a family history with somebody else in the family of the condition, or an abnormal ECG. But diagnosis is usually confirmed using imaging of the left ventricle, either by echocardiography or in some cases cardiac MRI. And again, the hallmark we're looking for is unexplained left ventricular hypertrophy, although other features may also be present. There may be a role of biopsy in some cases, particularly in those individuals with hypertrophy of unknown etiology. And there is a role of genetics, particularly in diagnosis of family members. Moving on to risk stratification. Now, this is not only based on family history and imaging, where a wall thickness of greater than 3 centimeters is another red flag feature. It's also based on exercise testing and Holter monitoring. And I'll go on to explain all of these things in turn now. So after history and examination, one of the most useful first-line investigations is a simple 12-lead ECG, which is abnormal in up to 90 to 95% of patients. And again, a wide variety of ECG abnormalities may be seen. Some patients may have a normal ECG or one which just shows minor abnormalities, such as left axis deviation, whereas in others, more marked features may be seen, such as voltage criteria for left ventricular hypertrophy, repolarization abnormalities, voltage criteria for left or right atrial enlargement, resting ST segment depression, pathological Q waves, or even left bundle branch block. And it's important not to miss the patient in atrial fibrillation, because as I mentioned, this is a cause of much morbidity in these patients. So moving on to echocardiography, now this is really the first line investigation for the assessment of left ventricular hypertrophy. And what we look in echo is not only the presence of LVH, but also the pattern. So for example, in this individual, we can see that the septum is probably normal in size, but there's a gradual thickening of the wall as we go through towards the apex, which is very nicely demonstrated on the short axis view and on the apical four-chamber view. And this is a patient with apical hypertrophic cardiomyopathy. Other patterns may also be seen. So this is a patient with concentric hypertrophy, and you can see quite severe hypertrophy with wall thicknesses approaching 3 centimeters. These images also show some important other features of HCM, such as a small cavity size and left atrial enlargement. And finally, hypertrophy may affect the septum in isolation, or the so-called asymmetric septal hypertrophy, or ASH. Now, apart from looking at LVH, echocardiography is also very important in assessing for other features of HCM. And these include systolic anterior motion of the mitral valve leaflet, or SAM. And this is demonstrated in the echocardiographic parasternal long axis view here on the left. Now, for those of you not familiar with this in the audience, this is an M-mode cut through the mitral valve. And what we have on the x-axis here is time. This area is represented by the septum, and these lines, the motion of the mitral valve. And essentially what we see here is that the mitral valve, instead of being shut in systole, is actually open, and it hits the septum and causes obstruction to blood flow. This is what it should look like with the mitral valve closed. And when there's obstruction to blood flow, we get the generation of outflow tract obstruction and gradient, which can cause breathlessness and syncope. When systolic anterior motion is present, the other phenomenon we see is mitral regurgitation, given that the mitral valve is open during systole. And again, this can cause breathlessness. So I just want to talk a little bit more about left ventricular outflow tract obstruction, because it is an important cause of symptoms in these patients. And 1/3 may have no obstruction at all at rest, and these are really patients who have other areas of hypertrophy apart from the septum, so for example, apical hypertrophy. A further third have obstruction at rest, but the final third have what we call dynamic left ventricular outflow tract obstruction. And what we mean by this is that although they have a normal gradient at rest, a gradient may be provoked by exertion or exercise. And echocardiography can be very useful in assessing this, either by provocation, for example, by making the individual perform a Valsalva maneuver during the echocardiogram, or more usefully during exercise. So to give you an example, this is one of our patients who complained of exertional chest pain and breathlessness. He had a low or normal resting gradient at rest, but when we put him on the exercise bike, this is what happened. So he developed a quite significant gradient of over 80 millimeters of mercury, and this helped us with his management and diagnosis. And just to finish off with, echo also looks at left ventricular function. Now, systolic function in HCM is usually normal or hyperdynamic, unless patients have reached the burnt-out phase. However, diastolic dysfunction is sometimes present. And again, for those of you not familiar with this term, this diastolic dysfunction reflects the failure of myocardial relaxation and a reduction in compliance. And what this essentially means is the left ventricle can't fill properly during diastole. And again, without going into too many details, this can be assessed using echocardiography by looking at the left atrial size, pulmonary vein flow, the transmitral E to A ratio and deceleration time, and the ratio of the transmitral E wave to the E prime ratio. So moving on to risk stratification, I've already mentioned that a history of syncope, a family history of sudden death, and gross hypertrophy on imaging may be risk factors. We then go on to perform exercise testing, and this is predominantly to look for the patient's blood pressure response. So this is a typical trace of somebody with an abnormal blood pressure response in HCM. And what I want you to note is this. So this patient has a relatively flat blood pressure response to exercise, by which I mean that there's a failure of systolic pressure to rise by more than 20 millimeters of mercury. In addition, this patient actually developed a drop in their blood pressure towards the end of exercise, and this is in contrast to a normal test where you'd expect blood pressure to rise gradually towards peak exercise and then tail off in recovery. So a blunted blood pressure response to exercise or a fall in blood pressure is another high-risk feature in the condition. And finally, to finish our risk stratification test, we perform ambulatory or Holter ECG monitoring. And this is the kind of thing that we're looking for. So on close-in inspection, this turned out to be ventricular tachycardia at a fast heart rate of greater than 200 beats per minute. And again, this is another high-risk marker. So before I go on to talk about management, I just want to mention a few other investigations. And those of you who were here yesterday would have heard an excellent talk by Dr. Rory O'Hanlon on cardiac MRI. So what does cardiac MRI add in HCM? Well, it can visualize the heart very well. We know that certain areas of the heart, particularly the anterolateral wall, the posterior septum, and the apex, may be poorly visualized on echocardiography alone. And up to 10% of cases of apical HCM may be missed on echo, whereas cardiac MRI can visualize the heart in much clearer detail. So, for example, this is a patient with apical HCM, short axis cuts, and you can see very nicely how the wall thickness increases towards the apex with cavity obliteration at the level of the papillary muscles. This is another view from the same patient, and again, the apical thickening can be seen very, very nicely. Now, cardiac MRI can also be useful in looking at other patterns of hypertrophy and also in accurate wall measurement. And in addition, it can show up other features such as left ventricular crypts or apical aneurysms when they're present. Now, apart from these features, cardiac MRI also has a role in assessment of the outflow tract gradient, looking for perfusion defects if a stress MRI is performed. But importantly, it can also detect the presence and pattern of late gadolinium enhancement. Now, depending on the study you read, this is present in up to 84% of patients, and it's important because it's a marker of scar or fibrosis. So to give you an example, this is the kind of thing we see. So after gadolinium injection, you notice these white areas of defects in the left ventricle. And in the first 3 patients, these are localized to the areas of hypertrophy. But in the final one, they're more widespread. And the reason this is important is that it's been proposed that the degree of fibrosis or the presence of fibrosis may have an impact on risk stratification and prognosis in HCM. So just to finish off on investigations, other useful tests are angiography, particularly looking for coexisting coronary artery disease. And loop recorders can prove invaluable when the cause of syncope is uncertain. So moving on to management. Now, this should obviously be individualized to the patient, But in general, there are 4 key principles. The first one is lifestyle advice. Second one is treatment of symptoms. Then we go on to risk stratify and try and prevent sudden cardiac death. And importantly, mustn't forget evaluation of family members. And I'll go through these in turn now. So in terms of general and lifestyle advice, obviously, as with every patient, there should be aggressive treatment of cardiovascular risk factors because coronary artery disease has a significant impact on survival in these patients. Low-intensity aerobic exercise should actually be encouraged. However, of course, strenuous, competitive, or burst activity should definitely be avoided because it has an association with sudden cardiac death. In addition, because patients have diastolic dysfunction and a stiff ventricle, they should be advised to keep well hydrated, particularly in hot weather and when exercising. And finally, because of an unstable underlying myocardial substrate and fibrosis, which makes patients prone to ventricular arrhythmias, they should definitely steer clear of all illicit drugs. So moving on to treatment of symptoms. So 2 of the commonest symptoms we encounter in clinical practice are breathlessness and chest pain. And the pathophysiology of these are multifactorial, as I've already mentioned. So they include diastolic dysfunction, left ventricular outflow tract gradient, and also myocardial ischemia. And the mainstay of treatment is actually beta blockers, which both slow the heart rate and decrease force of contraction. In other words, they have a negative chronotropic and inotropic effect. And these have a favorable impact on left ventricular filling and myocardial oxygen consumption. In addition, beta blockers can inhibit sympathetic stimulation during exercise and can help in blunting the left ventricular outflow tract obstruction. Now, an alternative to beta blockers are calcium channel antagonists, and the most widely used is verapamil. And this works predominantly through its negative inotropic and chronotropic effects. Verapamil should be used in caution, however, in patients with very, very high resting gradients. In terms of arrhythmias, again, these can be treated very successfully either with beta blockers or calcium channel antagonists. And in patients with atrial fibrillation, amiodarone can be very useful in trying to maintain sinus rhythm. And of course, in these patients, warfarinization should not be forgotten. And finally, end-stage heart failure for those patients who develop this is treated along standard lines, including the use of ACE inhibitors, beta blockers, and diuretics. So I just want to talk a little bit more about the treatment of left ventricular outflow tract obstruction. So if a patient has symptoms of this, as I've already mentioned, we can treat them with either a beta blocker or a calcium channel antagonist, obviously never both in combination. And if, despite optimal doses of these medications, patients still have symptoms, then we add in disopyramide. Now, this is a sodium channel blocker, and it works predominantly through a negative inotropic effect. And despite optimal pharmacological treatment, patients still have symptoms, then a more invasive approach needs to be taken. And this includes surgical myectomy, which is open heart surgery, where essentially the surgeon resects the hypertrophic septum, therefore relieving the obstruction. And this is really the first-line choice in most patients. However, an alternative is alcohol septal ablation. And what happens here is that we selectively inject vessels supplying the hypertrophied septum with alcohol, therefore creating a localized infarct, and the tissue there dies away. Now, this is second line really because it's been postulated that by creating an infarct, you may cause an extra substrate for ventricular arrhythmias. So generally, it's reserved for patients who are unfit for surgery or who have contraindications. So moving on to prevention of sudden cardiac death. Now, I've already gone through these, but just to refresh people's memory, the 5 main risk factors are unheralded syncope, a family history of sudden cardiac death, extreme left ventricular hypertrophy on imaging, so greater than or equal to 30 millimeters, VT on Holter monitoring, or a blunted blood pressure response on exercise. Of course, if patients have had a prior cardiac arrest or sustained VT, this is also another risk factor. And in general, we should look for these features on an annual basis. So what do we do if we find any of these features? Well, if somebody's had a previous cardiac arrest or sustained VT, then it's relatively easy, and in general, they should go on to have an ICD. What about the other features? Well, again, in the United Kingdom, if 2 or more of these are present, we again recommend an ICD. However, it's a bit more tricky in those who've got an intermediate risk, and for example, patients with just one risk factor. And in general, we have to individualize treatment to these patients. Some factors that may help us make a decision are other features in the condition, such as the end-stage phase, or in particular, an extensive amount of delayed gadolinium enhancement, which corresponds or suggests a large fibrotic burden. And finally, probably one of the most important parts of management is also familial evaluation. Today is all about sudden cardiac death and how we prevent it, and not having missed opportunities. And this is a crucial aspect of management of HCM. So it's recommended in all first-degree relatives. And our practice in St George's is to perform an annual review from early adolescence up till the age of about 20 to 21. And this is really with a history and examination along with ECG and echocardiography. Now, if by this stage there are no features of the condition, we then go on to 5-yearly review thereafter, unless, of course, people have symptoms in the interim. And in addition, in those families in which we know the mutation, genetic testing may also be offered. So I just want to end with a couple of slides on the natural history and prognosis. So in contrast to our previous thinking about hypertrophic cardiomyopathy, where it was in the past thought to be a very malignant condition, the overall mortality rate is actually now established to be relatively low, about 1% per year. In particular, we know that those who have no high-risk features have a very low event rate of about 0.5% per year and a low risk of sudden cardiac death. However, if 2 or more features, high-risk features are present, then the annual risk of sudden death is much higher, of the order of about 4 to 5%. And this is exactly why we offer these patients an ICD. However, one of the paradoxes is that up to 10% of sudden cardiac deaths may actually occur in patients with 1 or no risk factors. And this is actually one of the big challenges in hypertrophic cardiomyopathy, and how we manage these patients is the subject of ongoing research. And finally, it's important to remember that there is a correlation with age. And tragically, up to 70% of deaths, sudden cardiac deaths, occur in those who are less than 35 years of age, and 40% of these people may be entirely asymptomatic. So how do we know, or can we tell who goes on to develop end-stage heart failure? Well, we know that the majority of patients have a stable course and have the classic phenotype where ejection fraction is actually preserved. However, a subset of patients undergo adverse remodeling, and a small percentage of these end up having left ventricular systolic dysfunction. Now, which patient goes down this route is uncertain. We don't know what actually causes this, but several mechanisms have been postulated, including microvascular ischemia, myocyte energy depletion, and increased LV fibrosis. So just to summarize, hypertrophic cardiomyopathy is an extremely heterogeneous condition, and patients can present in a wide variety of ways. They may be completely asymptomatic or present with sudden cardiac death. And the diagnosis is confirmed on imaging, but a combination of tools is required for comprehensive evaluation, and risk stratification is an important component of this. And finally, management consists not only of treatment of the patient and symptomatic relief and prevention of sudden cardiac death in them, but also familial evaluation. I'd like to thank you for your attention. I'll be happy to take any questions.